Welcome to the Coy Pharmer, where we focus on cultivating clarity in the complicated world of pharmacy benefits. I'm Justine. I'm a pharmacist with 20 years of experience in the business of pharmacy. Today we're going to be breaking down MFP, or Maximum Fair Price, a new reimbursement concept that applies to Medicare drug pricing. Let's dive in.
You're looking for the cure, but you're stuck in the weeds, bringing you insights into pharmacy.
First, we're going to start with breaking down the acronym. What does MFP stand for? And we're going to talk about how drugs get included into the program. Then we'll walk through the timeline where manufacturers and CMS work together to establish the maximum fair price. Then finally, the fine print section in this video has quite a bit of meat in it, given this is a relatively new concept that has a lot of different consequences in the industry. So we'll talk through some pros and cons for manufacturers, some impacts to pharmacies and plan sponsors, how this program interacts with the 340B program, and lastly, talk about how this may impact manufacturer pricing and go-to-market strategy moving forward. So MFP stands for Maximum Fair Price. In concept, this was hatched to be able to help the federal government control pricing on drugs in Medicare Part D. In order for products to be eligible for this program, they need to meet a certain set of criteria set by CMS. The first criteria is that it must be a high-cost product. Next, a product with no generics or biosimilars available. Third, the drug must be Medicare Part D as in dog eligible. Interestingly, there is a time slot that makes drugs eligible for this program or not. For small molecules, the drug must be at least 9 years old, and for biologics, they must be at least 13 years old. And although not currently a part of the criteria, there is a planned expansion into Medicare Part B as in boy drugs planned for 2028 and beyond. Here you see just a really quick overview of the drugs that were the initial kickoff products that started this program in 2026 in select categories. And in 2027, the program is set to expand to additional products. Now that we've covered some of the basics, we're going to dive in and talk about how CMS and manufacturers work together to meet this new requirement and establish the maximum fair price in the market. Unlike some other indexes, like NADAC, for example, the maximum fair price is not necessarily meant to capture any particular existing market dynamics. It is rather a negotiation between CMS and the drug manufacturer, which may be informed by different pricing mechanics going on in the industry and in the commercial markets, but that is not necessarily the final resting place where the negotiations will land. In Medicare Part D, there are a lot of filing requirements. This leads the plans to need to be able to understand and underwrite some of the consequences of this pricing within their plan for the next year far in advance. So reflective of that need for extended timelines, CMS and manufacturers start well in advance of the intended go live to be able to start negotiating and setting the maximum fair price. So in an example where the pricing is being set for January 1st, 2028, we're backing all the way up to the third quarter 2026 for the program drugs to be selected. This means CMS is selecting the particular products that meet this criteria that they feel they would be able to produce savings by including products into this program. In the fourth quarter of 2026, the manufacturers would then submit data on the program drugs that are selected. This may include wholesale data, this may include the current AWP and WAC, and this may include additional data. Once CMS has a chance to look at the data that's been submitted, then negotiations start between CMS and the applicable manufacturers. This would take place during the first 2 quarters of 2027. Then in Q3 of 2027, the pricing would get finalized. In the fourth quarter, the members are actively shopping for insurance and may be looking at pricing, so no changes are generally able to be made in the fourth quarter to support that shopping experience. Then finally, on January 1st, 2028, the price that we started selecting Q3 2026 would go live, and that MFP would not change for any of these products until the next cycle on January 1st, 2029. So now that we've got some of the basics of MFP down, we're going to talk through some of the fine print. This particular industry construct has a lot of different consequences within the industry and may really impact strategy by a number of different players. So we're going to dive in and break down a couple of these different impacts along the way. So what are some pros and cons of this program for the industry at large? Some pros include that it introduces a level of pricing oversight on single source products, namely single source branded drugs that don't typically have competition in the market that may be difficult for CMS or PBMs to create control over the manufacturer pricing. This also creates some additional federal budget predictability and could also create some predictability within the plan sponsor's budgeting. And then finally, there can be lower out-of-pocket costs for members. If the product costs are going down as a result of these negotiations, the member may pay less at the point of sale. Some potential cons of the program that have been pointed out are that there's a limited scope. There's only a handful of drugs that have been implemented in 2026, slight expansion in 2027, but relative to all of the drug spend, this is not exceeding 50%. Another con is the timeline that we just talked about. This is a very long implementation timeline, and as things may occur in the marketplace, this could create some inflexibility in the market to be able to deal with market influences. There are some potential concerns that this could reduce specific R&D activities by the manufacturers. And then finally, there's limited transparency into the final price for several members of the market. As we break down how MFP plays out in practice, it's important to look at the experience of the pharmacies in this scenario. So before MFP, the plan sponsors paid the PBMs the negotiated rate. The PBMs would pay the pharmacies the negotiated rate, and the pharmacies would negotiate a rate with the wholesaler. Most of these rates are typically AWP based for these products that are single source brand. After MFP, there are key areas where MFP changes these negotiated rates and key areas where it does not. So the plan sponsor in this case now needs to reimburse the MFP plus a dispensing fee to the PBM, which is supposed to be the same rate as the PBM is paying the pharmacy. The pharmacies, however, continue to purchase at the negotiated rate. And as CMS drives the pricing potentially lower on these products than it was before, it's possible that the pharmacy margins may get compressed given they're still purchasing at the same rates, but they're obligated to fill the products for what may potentially be a lesser reimbursement rate than previously. When considering the plan impact of MFP, I feel it's primarily a plan cash flow advantage to be able to have drugs in the MFP program. So for example, in the current system on the left, plan sponsors would reimburse the PBM. Let's say the drug was $8,000 ingredient cost. They would reimburse that usually 7 days after the claim takes place. They would have to write a check to the PBM to reimburse for adjudicating that claim. Then, on some extended timeline, the PBM would invoice the manufacturer, garner the rebate for those products, and then pass that rebate back to the plan sponsor. Because there's a long time between the plan sponsor paying the claim and that rebate coming back, that can create more float for the plan sponsor to have to deal with. On the right side of the equation, we look at the brand drugs that are subject to MFP, and what happens here is there's a lower payment upfront to the pharmacies from the PBM, and therefore the plan sponsors are paying a lower amount right away. So now we're going to go back and revisit what each of the players in the drug value chain are reimbursing one another and talk about how this program interacts with a claim that may be 340B eligible. So for those of you not familiar with the 340B program, there will be another series in the Drug Pricing Index surrounding 340B. But to create a baseline understanding on the 340B program, the pharmacies pay the manufacturers a reduced price for providing a drug to a member that has a 340B eligible claim. In this case, the PBMs and the plan sponsors, by proxy, pay the contracted rate to the pharmacies, and the pharmacy is able to keep a higher margin than they normally would be able to because they're purchasing for a lower price. In the case of a drug that is simultaneously eligible for the 340B program and MFP, the pharmacy would still purchase the product from the drug manufacturer at the lower of MFP or 340B ceiling price. The difference comes in as to what the pharmacy is reimbursed by the PBM. So in this case, any drugs that are also subject to MFP, the PBM would reimburse the pharmacies at the MFP rate. In this case, again, the 340B eligibility is not disrupted. However, the pharmacy may have a lesser margin given they're being reimbursed less than they were previously. In these last couple of slides, there are some examples of how MFP may impact manufacturer strategy going forward. One such strategy may be that manufacturers may look differently at how to allocate research and development budgets across disease states. So, for example, there may be some disease states that have a higher incidence of that disease in the Medicare Part D population. As MFP is projected to reduce margins in the Medicare Part D population, that may create a disincentive for manufacturers to invest in R&D in that space. So, for example, if you look at a manufacturer determining if they should invest in research for prostate cancer versus research for hemophilia, the incidence in hemophilia for the Medicare Part D eligible population is less than that of those with prostate cancer. So this may skew R&D in some different directions and have some unintended consequences in the marketplace. So as we talked about in the beginning, there's a specific time slot that makes a product eligible for the MFP program. It's not necessarily immediately in the patent life cycle. So for small molecules, the patents get filed, and typically it may take 6 to 12 years to get to market launch. That leaves small molecule manufacturers with potentially 8 to 14 years of manufacturer exclusivity for a particular product. So we talked about the criteria for inclusion in the program having to do with how long the product has been in market. So for a manufacturer with a small molecule, the patent filing typically takes place, and then it takes 6 to 12 years to create a market launch. Once that market launch starts, that starts the clock ticking for when MFP eligibility will kick in. So these manufacturers may have 8 to 14 years of exclusivity on a small molecule, and the MFP eligibility kicks in starting at the 9th year. For biologics, market exclusivity can last a little bit longer, given some of the patents on devices and delivery. Therefore, the MFP eligibility is kicked out a little bit to 13 plus years. So the key take home here is that in the beginning of the life cycle of the drug, it is unlikely that the product will be subject to MFP. But then as the life cycle of the drug continues, the product may become subject to MFP. This may have unintended consequences of incenting manufacturers to increase their prices at launch to make up for MFP margin risk later in the cycle of the patent. As we discussed in the beginning, this program is fundamentally created to save money for the government. The projections are that $8.5 to $12 billion per year could be saved by the federal government from the institution of MFP. The problem here becomes that these manufacturers make up a significant portion of the United States economy. So manufacturers make up 3 to 4% of the Dow Jones Index and about 2 to 4% of the S&P. As we're familiar, these indexes have a market growth expectation attached to them. So given manufacturers have an expectation to create market growth and margin growth, they may need to offset losses in Medicare by increasing prices in other lines of business. If this occurs, this may create a dynamic where employer groups are funding some of the additional dollars that are not being paid in Medicare. This could create a dynamic where in the commercial market, employers are actually paying slightly more for products as the government in Medicare Part D pays slightly less. Thanks for joining us today to break down some of the components of Maximum Fair Price, a relatively new program instituted by the federal government. If you found this content helpful, I encourage you to like and subscribe to our channel. You can visit us at www.thecoypharmer.com to see some of our other content or to contact us about any customized training or consulting needs that your organization may have. Thanks. We'll see you next time.
You're looking for the cure, but